Equipment Lesson 18 covers criteria for image evaluation. The systematic checklist every radiographer applies before releasing an image. Before any image is sent to the radiologist, 7 criteria must be satisfied. These criteria are tested directly on the ARRT and used on every shift. 10 minutes. 7 criteria. Check every one before releasing any image. 1. Diagnostic density and exposure adequacy. Checked via D1 in digital systems. Too light means underexposed. Quantum noise may appear. Too dark means overexposed, unnecessary patient dose. The D1 is the objective measure. 2. Diagnostic contrast. Sufficient grayscale differentiation between adjacent tissues. KVP selection and scatter control determine contrast scale. 3. Recorded detail. Sufficient sharpness for the anatomical structures of clinical interest. Affected by focal spot size, OID, SID, motion, and receptor characteristics. 4. No distortion. Anatomy appears in true proportional size and shape. Size distortion means magnification. Shape distortion means elongation or foreshortening from beam angulation. 5. No artifacts. The image is free of any patterns or densities not representing patient anatomy. Repeat if artifacts obscure clinically relevant anatomy. 6. Proper identification. Patient name, ID number, date, facility, laterality marker, and technologist ID must all be present and accurate. And 7. Appropriate collimation. Collimation borders should be visible on all 4 sides. Visible borders confirm adequate field restriction, anatomical coverage, and LAR compliance. In digital imaging, exposure adequacy is evaluated by the D1, not by how the image appears on screen. A visually acceptable image with a D1 of plus 2.5 is not an acceptable exposure. The patient received excess dose. Digital compensation hides this from visual inspection. When D1 is significantly negative, quantum noise becomes the visible indicator of underexposure. Quantum noise, also called quantum mottle, appears as a grainy, sandy, mottled texture across the image. It is most obvious in soft tissue regions and uniform areas. Visible quantum noise means the image does not meet the criterion of adequate recorded detail. A repeat is required when quantum noise degrades the diagnostic information. The repeat decision: is the relevant anatomy visible and diagnostic? If yes, consult the radiologist before repeating. If there is significant quantum noise obscuring anatomy, a repeat is required. If there is an artifact obscuring clinically relevant anatomy, a repeat is required. If the image is overexposed but diagnostic, do not repeat. Document the D1, investigate the cause, and correct technique going forward. Every repeat is 100% additional dose to the patient. The decision must be clinically justified. Gross underexposure, severely insufficient technique. Anatomy is not visible. D1 significantly below target. Quantum noise predominates. Always requires a repeat. The image is non-diagnostic. Identify the cause before repeating. Was technique wrong? Was centering off? Was the patient too large for the selected AC chamber? Gross overexposure. Excessive technique. D1 far above target. The image may appear diagnostic visually. Do not repeat unless the radiologist determines it is non-diagnostic. Repeating an already diagnostic overexposed image doubles the patient's dose for no clinical benefit. Document, investigate, and correct going forward. Documentation. Document all repeat exposures with body part, reason, and corrective action. Document elevated D1 values with investigation findings. Track repeat rate monthly. 5 to 8% is the acceptable threshold. 5 identification requirements. Patient identification. Patient name, ID number, date, and facility must be permanently imprinted on or attached to the image. A missing ID means the image cannot be legally released for interpretation. Laterality markers. RRL marker must be placed physically in the primary beam before the exposure, not added digitally after the fact. An absent or incorrect laterality marker is a patient safety event. Wrong side errors are a sentinel event in healthcare. If the marker is missing, the image must be repeated with a marker placed in the beam. Positioning indicators. Upright or erect markers confirm the patient was standing, important for demonstrating air fluid levels. Decubitus labels and time markers for timed series examinations. Collimation evidence. Borders visible on all four sides confirm adequate field restriction. Absent borders on all four sides indicate the X-ray field exceeded the receptor. The patient received radiation to anatomy not captured on the image. This is an ARRT, a violation regardless of image quality. Document and correct. In technical factor metadata, DYCOM metadata embeds technique factors, AEC status, and D1 values into every digital image. Review these data when investigating any image with suspected technique errors. The evaluation table on this slide covers 6 assessment dimensions. Contrast evaluation. Can adjacent structures be differentiated? Is the correct scale, short or long, being used for this examination? Inadequate contrast indicates a KVP or scatter control problem. Recorded detail. Are the edges of bone, soft tissue, and relevant anatomy sharp? Blur indicates motion, large OID, large focal spot, or too short in SID, size distortion. Magnification is always present in radiography. The question is whether it is predictable and uniform. Unexpected non-uniform magnification indicates incorrect SID or object to image distance. Shape distortion, elongation, or foreshortening. Both indicate an incorrect central ray angle or receptor position. Density uniformity. Non-uniform brightness across the image may indicate anode heel effect, grid cutoff, or collimator misalignment. And artifact identification. Any pattern not representing anatomy must be identified and assessed for its impact on the diagnostic information. Repeat only if the artifact obscures clinically relevant anatomy. 3 image evaluation questions. The answer is B. Repeat the image. A D1 of -1.8 indicates approximately 34% less radiation than needed. When visible quantum noise is present in soft tissue regions, the image does not meet the criterion of adequate recorded detail. Soft tissue detail, paravertebral muscles, intervertebral foramina, is clinically relevant for lumbar spine evaluation. Adjusting window width does not improve signal-to-noise ratio. The correct action is to repeat with corrected technique. The answer is C. Repeat the image with correct R or L marker placement in the primary beam. Laterality markers must be physically present in the primary beam during the exposure. Post-acquisition digital annotation is not an equivalent substitute in a legally or clinically acceptable manner. An absent laterality marker is a patient safety issue. Wrong side errors are a serious sentinel event. The image must be repeated with a marker properly placed before the exposure is made. The answer is B. The field was larger than the image receptor on all sides. Absent collimation borders indicate the X-ray field extended beyond the receptor. The patient received radiation to anatomy not captured on the image, a direct LAR violation. Regardless of image quality, this is a collimation failure that must be documented and corrected. You covered all 7 image evaluation criteria: digital exposure evaluation using D1 and quantum noise recognition, gross exposure errors, and the repeat decision framework, identification marker requirements including the critical laterality rule, collimation evidence requirements, and systematic contrast, detail, and distortion evaluation. Apply these 7 criteria to every image before it leaves your hands.